Looks like maybe Rosalie might be on her way. Good morning, everybody. Let me just check to see what she said before I go ahead and get started. Don't have it. Okay. All right. Good morning, everyone. Thank you so much for coming. Um, the weather has given us a new treat. So we may all be in for a little bit, everybody except Mary Williams Stover for the weekend. But I hope everybody is safe and warm as we go along today. So I'm going to go ahead and get started. I need to send a link to Rosalie. So want to greet you by saying Happy New Year. Welcome to 2025. So again, thank you so much for being with us today. So we'll get started because we only have about an hour. And I'm going to ask Mary if you would go ahead and introduce our speaker for this morning. We have a very exciting presentation before us. Thank you.
Yes, thank you, Daryl. I am excited to introduce Lindsey Golden, who is the new co-chair of the Black Indigenous People of Color Work Group. And Lindsey is bringing information to us about health equity and Alzheimer's. We had spoken when we first talked about developing the health equity work groups about the need to be inclusive and understand the impact of disabilities and older adults in North Carolina, and that we would integrate disability conversation into each of our work groups. And so the BIPOC committee has been focusing on tobacco cessation, educating communities, and developing partnerships with organizations to help us to bring information and advocate and encourage smoking cessation for older adults, bringing awareness of initiatives such as No Menthol Sunday, an initiative of the Center for Black Health and Equity, partnering with organizations where we could present tobacco prevention and control and treatment strategies. But we know that there are relationships between cigarette smoking and other diseases. And so I'm really delighted to introduce Lindsey, who will bring that information to us from a broad perspective, and then really help us to understand more about health equity and Alzheimer's and the relationship on BIPOC and other communities. So, Lindsey, welcome.
Thank you so much, Mary, and I will reshare my screen, so give me just a second. Okay, can everyone see the presentation? Perfect. Well, thank you guys so much for giving us the opportunity to update the Health Equity Committee on what dementia and health equity looks like and why we have to wrap in health equity to any brain health initiatives that we're doing. So I am Lindsey Golden, the Director of State Affairs with the Alzheimer's Association. I've been with the association for 4.5 years, have loved everything that we've been able to do on our policy side and supporting those living with dementia and their caregivers. That's really been our main focus and how we can provide additional support. And that works across the association. So we have team members that are working on care and support. So free educational programs that we can provide to our communities. Anything from knowing the early warning signs of Alzheimer's to what are 10 healthy habits for your brain, to really specific information around caregiving and managing your finances after a dementia diagnosis, which is really complicated. So really excited to share with you guys a little bit about what dementia looks like nationwide, bring it down to our state, but then how dementia is impacting these groups that are disproportionately affected by the disease, along with a lot of other diseases like Mary talked about, and then how we can support those communities in our state. So in the US, there's almost 7 million Americans living with Alzheimer's disease. That's just Alzheimer's disease, not other types of dementia. So it's a lot of people. I think most people on this call, I know I've interacted with you in some way, have either a personal connection in your family, that you've been a caregiver, you've had a family member living with the disease, or know someone in your networks that has. So unfortunately, the disease is rapidly increasing across the country, but certainly in North Carolina, we are seeing huge impacts. So with the almost 7 million people living with the disease, there are over 11 million Americans who provide unpaid care for people living with Alzheimer's or other dementias. That's probably really undercounted because a lot of people don't really consider themselves caregivers. Maybe they help on a more as needed basis for their family members. That technically makes them a caregiver, but they may not consider themselves in that role. So the unpaid time equates to over $347 billion. So you can tell, most of these unpaid caregivers have full-time jobs. They're working, they have children of their own. So they're taking care of children and taking care of their loved ones that they're caregiving for. It's an immense burden on our society. And this really falls into some of our diverse populations as being disproportionately affected by caregiving and its toll as well. So in North Carolina, we have just over 210,000 people living with Alzheimer's. This data is all as of last March. So we will get updated numbers in our annual facts and figures that comes out later this year, but we do expect to see a rise every year since we've been collecting this data. These numbers have risen significantly. Prior to this, we were at 189,000. So we are rapidly having more people develop Alzheimer's in our state. That's a combination of we have more diagnostics available now, more people are having conversations with their physicians, but then the prevalence is also increasing at the same time. In North Carolina, we have 373,000 caregivers who are providing unpaid care. So this does not count anyone that gets paid for their caregiving. The Medicaid cost of someone living with Alzheimer's is 1.3 billion. That is a huge cost on our system. And then you can see through the statistics across the bottom, it really is just showing that the disease is rapidly increasing. And we don't have necessarily the support systems in our state to support that increase in people living with the disease. So we would need almost a 240% increase in geriatricians to meet the needs. And we just don't see that tracking. So we're going to be behind, which is going to lead to longer wait times, further people have to travel, which disproportionately affects the groups we're going to talk about in a few minutes. So how can we make sure we are supporting these communities? Because this is a huge percentage of our population. So this breaks down the county level prevalence. So if you are familiar with North Carolina, you'll notice some of the darker areas are areas where we have much higher prevalence of people of color. So in the kind of the greater Greenville area, Pitt County, where we have a large Black population, you can see the numbers of prevalence are a lot higher. It's also a lot higher on the southeastern side of the state where we have a lot of indigenous populations. There is a huge percentage of people in those areas, especially around Lumberton, that are from the Lumbee Indian tribes. So we can see that there are certainly areas disproportionately affected by the disease. And those areas aren't super close to our big medical facilities. So oftentimes getting care for a neurologist, for a specialist is extremely difficult. A lot of folks have to travel to the Triangle to get their care, which often is an hour and a half, 2 hours each way, which puts an immense burden on caregivers. So wanted to just show the county prevalence map. It's fairly new data that we have had. We've had it for about the last 2 years. And it's really helpful to kind of break down what dementia looks like specifically versus, just giving our whole state numbers. So when it comes to health equity and dementia, the Alzheimer's Association has really made this a focus since about 2018. We know there are certain groups, like it says on the slides, Black Americans, that are much more likely to develop dementia. And with that, we have made sure to bring in extra support services, bring outreach to these communities so that way we can build trust and have these conversations within groups that really, really need it. So in the US, so these are all US statistics, they're not necessarily North Carolina specific, but Black Americans are 2 times as likely to have Alzheimer's or another dementia, and are less likely to receive a diagnosis. That is from a combination of reasons. Less likely to receive a diagnosis. A lot of people in this community aren't, for a lot of historical reasons, don't trust our medical community and have a lack of trust. So maybe it's a challenge of getting them to go to a doctor when they're seeing signs. People also feel they seek discrimination. So I think a lot of us are well versed in how Black mothers who are going through the childbirth process are treated very differently than white people going through that same process. It's no different in different disease groups. So these people feel like they are discriminated against. You're not necessarily going to seek care if that's the experience that you're having. And nearly 2/3, which I think is a really high statistic, believe medical racist or research is biased against people of color. A little bit later on, we'll talk about some of the things we're doing to try to address that and make sure that we have health equity brought into clinical trials across the dementia spectrum. But I think these statistics really speak to why we need to bring some more outreach and understanding to these communities. So here's a couple more statistics. So only about less than 50% of Black Americans report they can confidently access culturally competent care, so people that understand them. 35% of people that are Black say they're concerned about Alzheimer's and dementia. This statistic is really alarming. We've seen this in North Carolina specifically. A lot of people don't really understand the disease. They don't want to talk to a doctor. Sometimes the disease itself can be stigmatizing. So having those conversations with your community, with your family can be really challenging. So we want to see that number really go the different direction, and see that people really do have an understanding of the disease, why it matters to get a diagnosis now that we're in the era of treatment and have treatment options. So outreach is really, really going to hopefully impact these numbers over the next couple of years. I think that the statistic around understanding significant cognitive loss is a different part of aging. It's not normal aging. That is a big disconnect that a lot of people have, whether they are a person of color or not. A lot of people just think dementia or Alzheimer's is a normal part of aging. It's not. It is abnormal brain changes that lead to the disease developing. Not everyone that's aging that has memory loss has dementia, but it's certainly a conversation that we want to have. So I think all of this really kind of builds the case later for the work we're trying to do within these communities. So within women doesn't necessarily fall in the BIPOC communities, but if you are thinking of Black women, way more women have Alzheimer's disease than men. So when you're looking in Black women, you're going to have higher prevalence as that. It's just under 2/3 of people living with Alzheimer's in the US are women. And most dementia caregivers are women. So you are more likely to be impacted by the disease, but the caregiving burden is also a lot more on your plate. So when it comes to Hispanic populations, Hispanics are a little bit lower than Black Americans, but they're about 1.5 times likely as white Americans to have Alzheimer's or other dementias. That's again a really high statistic. Within this, there's some of the same statistics we kind of talked about with Black Americans. They're a little bit better for this group, but still, we need to address this. So we do have a huge Spanish-speaking population across the country. The association has really put a focus on making sure we can get all of our resources to Hispanic groups, the same that we do for English speakers. So we have an entire version of our alz.org website where the entire website is in Spanish. That has been a change we've made in the last couple of years, and I think it's been really helpful for Spanish speakers in North Carolina that we've interacted with personally, to have those same resources, to not, some organizations, and we in the past used to have kind of one-off situations where we'd have handouts or maybe one program that we would offer in Spanish. Now we have an entire repository of information. We are working on that direction in a couple other languages as well, but I think the Spanish function, it's really easy. You go to alz.org, and at the top it has an Espanol option, and you just click that and it switches everything to Spanish. And I think we're really proud of trying to bridge the gaps with that community. So when it comes to Asian Americans and Pacific Islanders, about 46% say they're concerned about developing Alzheimer's or dementia. So it's a little bit higher than the Black American population, but still 46 people, 46% of people is not really what we would like to see. So we are addressing some of these groups specifically through our Healthy Brain Initiative. So we have a roadmap that comes out every few years, and we have one that just rolled out. I will share it in the resources after this, focused specifically on American Indians and Pacific Islanders and Alaskan Natives. So it's really targeting these populations. What are some of the big statistics we know? How can we support them? And then providing ideas and resources for these local communities where these populations exist to support them. And I think it's a really nice way to, again, work really hard to meet these communities where they're at, what they need, to move on some of these metrics. So when it comes to caregivers within these BIPOC populations experience greater care demands, less use of outside help, greater levels of depression compared to white Americans across the board. So I think this is really important. If you have been a caregiver, I know some of you on this call have been a caregiver for a loved one with dementia or another disease. Caregiving is extremely hard on your health across the spectrum, your mental health, your physical health. We now have data around what it is doing to physical health of caregivers. So if you're not asking for help, if you are not seeking support or talking to people about it, it can lead to all of these things. Oftentimes, caregivers are now passing away before their loved one with dementia that they're actually caring for because of the health toll it takes. So it's not just supporting these BIPOC communities that have dementia, but it's really looking at the full family unit and the caregivers and how can we provide support specifically to these groups, knowing the extreme challenges they face. So when it comes to Native Americans and Alzheimer's, we expect this to rapidly grow by 2060, which is kind of the new year marker we're looking at for a lot of these statistics. So that's a huge increase. So in North Carolina, we do have a pretty big population of Native Americans. We have, I think, the Cherokee Indian group is the biggest Indian population west or east of the Mississippi. So we are looking at a lot of people that need support. And right now, there's not really a big focus on brain health or conversations around dementia for these populations. So we're looking at in North Carolina with these groups, what can we do? Can we work to bring right now? We have Healthy Brain Initiative grants where we are trying to bring some of those funds to North Carolina to see what we can do to work and bring awareness and education to our Native population. So definitely is one of our focuses as well. And then I know this doesn't necessarily fall into our BIPOC community necessarily, but we do have a health equity focus on LGBTQ plus Americans. And they are also experience more challenges with dementia. They are more likely to live alone, not have children to help, and not have a caregiver, which gives a lot more complexity to managing the disease. If you don't have a caregiver that is close to you, maybe living in the home or geographically close, it makes managing the disease a lot harder. So 40% of LGBTQ plus report that their support networks become smaller over time. And then having issues with access to care for these groups is a challenge as well. So we do have LGBTQ specific resources and programs that are targeted this community that's experience really different and unique challenges. I know in North Carolina, we've had a lot of uptick in kind of desire for these programs in Charlotte and Raleigh specifically, but we know other areas across the state need them. So making sure that people know we have support. We are a very inclusive organization as a whole because the disease does not discriminate. It will affect everyone if it is kind of in the cards for you. So we want to make sure they have the resources they need. So before we wrap into how we're trying to address this, this just shows you a kind of high level view of discrimination when seeking healthcare. This is general healthcare, it's not dementia specific. But I think when these groups may be thinking about talking to a doctor about changes they're experiencing in their life, or maybe what's going on with their cognitive health, it doesn't really matter. If they think they're going to experience discrimination, it's going to bleed into any type of doctor. So knowing all of that and kind of the underlying need to support these groups, how are we working to integrate these health equity ideas into our dementia conversations and priorities that we're having? So I have a video on social determinants of health for time. I'll send it in the follow-up, but it really talks about some of the underlying barriers to dementia risk. So social determinants of health is a huge conversation when we're talking about equity and especially health equity. So we know kind of access to good healthcare, access to resources are huge determinants. Healthy foods, exercise, the ability to do those things, good sleep, environmental issues all lead to a chance for better health outcomes or worse health outcomes. And that is no different from dementia. So it's a really great kind of video that talks about some of these areas. So we'll share that afterwards. So I mentioned this at the beginning. So this is something we are really addressing when it comes to our BIPOC communities is underrepresentation we see right now in dementia clinical trials. There are billions of dollars being spent every single year in our country on dementia trials. So it's looking at Alzheimer's, it's looking at Lewy body dementia, frontotemporal, all kinds of different things, treatments, how we can maybe prevent the disease from a wide array. But what we see is most of the people enrolled in these clinical trials are white, wealthy Americans. That is not representative of the people living with the disease. So we are really working to make sure racial and ethnic minorities are represented in trials. That means when we are recruiting for our clinical trials, we have had this specifically happen in North Carolina. We had the Alzheimer's Association's largest funded study take place in Winston-Salem out of Wake Forest called the US Pointer Study. And one of their big focuses was making sure we had a much higher percentage of diverse people included in the research. We want this because you can't have good research that represents all genetic backgrounds and makeups if you don't have those groups involved in the research. People with the Caucasian backgrounds, their underlying DNA is a little bit different from these other groups. So we want to make sure that it's going to work for anyone. If we're looking at treatments and investing in those, knowing how it will affect all of those populations is really important. So you can see the percentage on the screen, 1.2% of people involved in Alzheimer's clinical trials were Black, 5.6 were Hispanic and Latino. When I first saw those statistics last year, I was blown away. That is a horrible percentage and something that we are working through both with NIH funded research trials, but then certainly with the Alzheimer's Association, so we can turn that around. The North Carolina Brain Health Registry is also doing amazing work around this. They have a huge focus, as well as we do, on making sure that our diverse populations are included in clinical trials, and making sure those people feel comfortable and are aware of the opportunities we have to participate in the science. So it takes a lot of trust building within the community to talk through these trials. Obviously, clinical trials in the past have had really, really horrible outcomes and abuses that have affected these populations. So we know that that is something that we have to work hard to advocate for, the need for more representation, but then there's a lot of trust that has to be built before we'll get there. So there really is no time to waste with all of these. The earlier we can have conversations with people about Alzheimer's and other dementias, raise awareness on maybe early warning signs, that means the earlier people can have conversations with their physicians and get a diagnosis. As we now have treatments available that only work in the earliest stages of Alzheimer's disease, it is critical when people start seeing signs that they're having conversations early with their family and their physicians to get a diagnosis. A later diagnosis leads to a whole host of problems. This specifically happened in my husband's family. His grandmother had a very late diagnosis because her doctor wrote it off for years. So it made our experience a lot more challenging. So with that, in North Carolina, we really want to see an increase in brain health campaigns with a health equity focus in our state. These brain health campaigns are really designed to educate and raise awareness on kind of low-hanging fruit, the early warning signs like we've talked about, healthy habits you can do for your brain, but getting that information out. All of our information is only as good as people are seeing it. We also want to integrate our understanding of health equity and risk factors into policy decisions. In the next slide, I'll talk about some of the risk factors that really overlap with our big disease, like Mary talked about at the beginning, and how dementia and tobacco use are certainly connected in these groups. And we want to make sure that people are aware of that so they can mitigate some of those risk factors. And then collaborating with people and organizations invested in this issue. We have amazing folks working in the dementia space. The Alzheimer's Association is just one of many organizations tackling this issue. I saw Heather Carter, our Dementia Services Coordinator with DHHS's Division of Aging, on the call. She's working from the state level to address some of these issues and support those living with dementia and their caregivers. But it takes everyone. So we're really hopeful that our work in the committee can be shared out through the coalition and then to our communities to really address some of these issues. So one of the big focuses we've talked about in our subcommittee is the importance of early detection and diagnosis and educating people on cognitive health. So these two are really connected. So when we are talking about cognitive health, normal aging versus not normal aging, and maybe signs of dementia, normalizing cognitive health conversations, highlighting the benefits of early diagnosis, those are all hallmarks of what we want to integrate into the information we are starting to share out through our networks. Because this is really what people will need as the basis to get to those higher levels, whether it's a diagnosis, maybe it's more resources, maybe it's kind of once you have a diagnosis, getting that next level of support and care. This is really the foundation that all of that will build on. So when it comes to building in our risk reduction conversations into what we plan to roll out, these are some of the bigger disease groups and issues that can reduce your risk of having dementia or increase your risk of having dementia. So cardiovascular health, we say what is good for your cardiovascular and vascular system is good for the heart, it's good for the brain. So with that, diabetes and obesity lead to higher chances of dementia. Lack of sleep, lack of social engagement, TBIs all lead to higher levels of dementia. So knowing these things, people can modify their behaviors. That is what the clinical trial that took place out of Wake Forest was looking at, is how can we tweak some of these things in our daily lives to hopefully lessen the chance of developing dementia. Those clinical trial results will be shared this summer, so we're really excited to see what that looks like. But we know that if you are exercising more, if you're eating healthier, you're sleeping more, it's better for your overall health, which is very much better for your brain health. So with knowing kind of those big goals and how we can integrate those things, our goal is to start with a high level introduction to the disease, warning signs, and prevalence information to share with communities disproportionately affected by Alzheimer's. So these are all of our diverse communities that we talked about previously. We would love for this to kind of launch in a one-pager that can be shared within our network. So something that is super easy to roll out, to share as a PDF in an email attachment, or to print out and have in your offices, or to share with health departments, any of your partners. So that's what we hope to come up with as a committee. I think we would also love to see some social media graphics that can be shared that take some of the information that we know about the disease, target it to certain groups, and share it within our networks. Social media is a huge tool in raising awareness, especially if we don't have funds directly to fund a brain health campaign on, traditional media, a billboard, a commercial, that type of thing. Social media can bridge some of those gaps. And then the goal is, once we do kind of the initial touch points, is for the subcommittee to have conversations about other ideas and how we can build upon the initial work. And with that, we would love to bring in some other voices into this conversation about how we can best bridge kind of these brain health conversations and about dementia, raising awareness for the disease for the health equity groups. So if you're interested in getting involved, we would love to have you join our BIPOC committee that's working on these issues. So you can email me or let Mary know, or Gerald, and we'll connect you with our group. But I think, we will be meeting on this on a monthly issue, and certainly look forward to all of the conversations we'll be having with everyone and brainstorming, because I think we have a lot of information at the association, but everyone else brings in your own expertise and what you've experienced personally, but then in your professional work as well. And I think the collaboration that we'll have within the coalition will be really nice to get out that information.
Wow. Thank you, Lindsay. That was excellent.
Thank
I
you.
see you have another slide.
Yep. This is just resources. So Daryl has the PDF that'll have the links, so you can click on these. So it's just a couple of really good information focus on health equity. So feel free to look at these or share them out with your networks.
That is great. This was very informative and we really appreciate the way you put this together to show how everything kind of fits together and to talk about Alzheimer's and dementia across the spectrum of the populations that we are particularly interested in for our work with the Health Equity Committee. I saw that Heather, I believe, had a comment in the chat regarding an intern, Heather. Was it Heather Altman?
Whoops, sorry, I was having
I
some
think that would
technical
be,
issues, so I called in on my phone. Can you hear me okay?
Yes, we can.
I'm always looking for very specific projects for interns. And so, yes, Lindsay, I ditto Heather C's comment about excellent presentation. And all of a sudden when you said, oh, we want to create a one-pager, it made me think I'm meeting with a new intern next week. And I was like, oh, this could be a great project. So do you have staff to work on that one-pager or volunteers, or do you need some more helpers?
I think we could definitely use some more help. And I think on the social media side as well, creation of graphics and kind of what we can share out. That would also probably be a great project to tap into. So yeah, interns are great. Would love to have her.
Okay, great. So you and I will connect offline. Thanks.
Perfect.
Daryl, could
Yes.
Lindsay go back to the slide that showed the prevalence rate in North Carolina?
Yes, let me pull that up. Like the county map.
Yes, please.
Yeah. That one, Mary?
Yes. So it's particularly caught my eye because I grew up in northeastern North Carolina. In fact, I grew up in Bertie County, which is the reddest of all the
Mhm.
counties that listed. And since I have Alzheimer's and dementia on all the sides of my family that live in Bertie County, it certainly caught my interest. But I'm wondering if the BIPOC committee wants to do something like you're talking about developing this flyer, but if you're interested in working with people that can help you in this area, East Carolina Medical Center has got a lot of focus on outreach to the community about Alzheimer's. I know this personally because my sister works in the area of that. So I would think that if the committee wanted to take on a project where you really see a great need to do something, there are ready-made resources there that we could help get you connected to. That would be, whether it's just distributing information or trying to do something a little bit more.
I love that idea.
Yeah. Me too. Me too. So that's another discussion, Lindsay and Mary, for the committee um, to look at. And Mary Bethel, do you have, like you said, your sister works with East Carolina with the medical center,
Right.
so I'm assuming you may have a contact.
Yeah, I could, certainly talk to her about y'all when y'all get to that point. But I
Okay.
think it's really interested. I mean, Bertie County is way above everybody else. Now, I know that one of probably the risk factors in that area is you have all those counties that are dark
Mhm.
have high prevalence of African American population, and also a good number of Hispanic population too. So that itself may be it. But I'm wondering if there are like environmental factors and other types of things that are in there. I don't know if you guys have looked at what you think risk factors are, particularly in those areas that are high risk or not, Lindsay.
We have, because
Mhm.
we've gotten a lot of questions with legislators. We share this out strategically so that way people can see, when we just talk about North Carolina, like 210,000 is really hard to conceptualize. So this map is helpful for people to see like, oh, that's where I grew up. Like that's a lot worse. So I think it's a combination of the diverse population that lives there and then some of the risk factors across the board with these deeper orange counties. We haven't had information collected on like specifically like if there's a certain environmental factor that may have played a part, but I think that eastern part of the state definitely has some more challenges than maybe the western side of the state that is a lot lighter. And something else that we get a lot of questions on is like, oh, some of these counties look really good, they're light. But when you look at the chart, even the almost white counties, the minimum is 8% prevalence in the counties.
Mhm.
So that is really high. So it looks good comparison to Bertie County that has 16 to 18%, but we're still looking at a bunch of counties that have between 8 and 10 of their population. A lot of these are poorer counties that don't have the
That's
resources. If you are on the very most western part of the state, at best you're driving to Asheville to have a conversation with a neurologist. And Asheville is becoming a neurology desert. We've heard of several neurologists that are no longer seeing patients or working in the area. So it's really hard to get care. So accessing care once, maybe getting someone comfortable to have a diagnosis is a challenge in itself, but then getting access to that care is a huge challenge.
Yeah, Lindsay, and I was thinking because I used to work in Martin County and Halifax County. They're tier 1 counties. So you have so much poverty in those areas too. So the correlation between that, the racial breakdown, as well as the other environmental factors, I'm sure has a lot to do with that.
Yeah, and the social determinants health video that
Mhm.
will be shared afterwards, it talks about kind of the financial piece that impacts us from birth. If you are born in an area that has less economic development or opportunity, I grew up in West Virginia. That's certainly the case in most of West Virginia. People have a lot more health issues in those areas
Mhm.
because there's just a very real difference in those communities versus Charlotte or Raleigh that have endless resources.
Yeah.
Carol, I see a question from Heather Altman asking about the
Okay.
data collection process. And she basically, how is the data collected, I guess, where we know what 210,000 people in North Carolina? Is this based on like Medicare data reporting, or how exactly how do they do that?
So we fund the research that brings us kind of the 210,500 number, the 373,000 caregivers. So we do that on a yearly basis. So the data normally tracks a year behind for those big statistics. So what we shared this year in 2024 was actually captured in 2023. And I don't remember off the top of my head where we get that information, but I can look that up and share that afterwards. But we did a new partner to collect our data, I think in 2022. So our data used to track a couple years behind and looked at a couple different factors. So now it's a lot more accurate data, which we're really excited to have. And the county level data is brand new, as I said, as of 2 years ago. And a group did that for across the country. So every single state has county level statistics now.
Mhm. So here was my, I'm checking in to see if you can hear me. Great. Here's my circular thought process question. In counties where there's a greater lower income population who may be getting more public medical services or through Medicaid, that the reporting will be different than, so here I am in Orange County, and I was just talking with a private doctor's office. If you've got more people in private medical care, and concierge medicine, so who may not be reporting their population of patients who have it, it could skew it that because their people are getting more private medical care, it's not showing up. So I was just geeking out on the data collection and wondering if that also showed something there.
Yeah, I do not know, but I can definitely look into that and see where they're pulling that information from because that's an interesting question that we have not gotten before.
Oh, okay.
Thank you, Heather,
I'm
for that
geeking out in my
question.
pajamas.
And you know what, Lindsay, I'm hearing more about the frontal lobe dementia. I have a couple of friends that their family, they're experiencing that, and they're young. They're not old,
Yeah.
whatever
So
that means. Yeah, to
yeah,
people.
there is definitely a rise on people being diagnosed earlier. So we get the question a lot of, and the data I think is new, so we don't have a good insight into all of it yet, but people are being diagnosed younger. On an anecdotal level, we have had more people in the last 2 years get involved with us that are in their 50s. than ever before. Like a lot of people are being diagnosed in their 50s. We had someone that was diagnosed in their 40s a couple months ago in North Carolina. So it is becoming more prevalent to see people younger. That's a combination of people are seeing warning signs earlier and having those conversations with their doctor as we're raising awareness about the importance of doing that and getting a diagnosis. But then, is just early onset on the rise itself. So hopefully we'll have some better insight into that. But I think the point you bring up about frontotemporal dementia and other dementias as well, whether it's Lewy body, which has been made a little bit more famous in the last couple of years, Bruce Willis, that's what he is living with, along with aphasia. So sometimes as we have better diagnostics, I mean, you used to not be able to tell if someone had dementia until you did an autopsy after they died. Now we have diagnostics that you can do while people are still living and have the disease. But we are doing a lot of work at the association to educate medical professionals who are having these conversations on what the different dementias look like. The actual dementia training in medical school is very, very little, like almost none, in comparison to the full medical training that physicians receive. So making sure doctors understand the disease, know what to look for, and then do those diagnostic processes is really important. So I think that's part of where we're seeing some of the uptick as well, as physicians know about FTD and to look for that, and we have better diagnostics to tell whether it's Alzheimer's or a different type of dementia.
Thank you so much. Yes, that's important. Mary, would you like to comment at this time, and then you can move into your BIPOC report if you like. Thank you again, Lindsey. This was very informative. Thank you.
Yes, thank you. Thank you. Thank you so much. Great presentation. Would love to make the slides available to members of the work group who are not present today. And I did also make a recommendation about partnering with women's organizations, thinking about caregivers. There are historically Black organizations, sororities, for example, in across North Carolina that may be a great resource to bring awareness about underrepresentation in clinical trials, but also bringing information about the early detection. So love that information and would recommend we do more about that. So BIPOC, you heard, one aspect of our committee work. The other aspect is we are continuing to talk about opportunities and strategies for increasing relationships and partnerships that are more effective, I would say, to increase awareness about tobacco cessation treatment and its effectiveness with regard to BIPOC communities. The work group needs to connect so that we can really hone in on what our next steps are going to be. And so I just want to recommend that folks who are on the call who are interested in connecting with us, we meet on the third Thursdays at noon. And so if you are interested, please put your name in the chat and send that, and I will contact you and send you an invitation so that we can continue to develop the strategies that are more effective in spreading awareness about smoking cessation, tobacco cessation, and effective treatments and relationships to reach older adults. Just as Lindsey identified, there's a lack of awareness, for example, or a misperception that aging and Alzheimer's and dementia is the natural cause of aging, right? If you quit smoking, even as an older adult, you can extend your life. So there is a benefit there, but there are strategies that are not really known or not really being utilized effectively for tobacco treatment and cessation. And so we really want to and need to reach more people to help them understand what are those effective strategies. And then there are communities that are working together, such as we know in Mecklenburg County, for example, are working to engage communities to bring awareness about both policy changes needed and about increasing resources. So that's what we're going to continue to talk about. How can we effectively reach and partner with others so that we can reach more people?
Absolutely. Thank you so much, Mary, and the work of the committee. We will make sure that the PowerPoint that Lindsay shared will get out online. And Mary Beth, I think we can get that out on our website as well, right?
Yes, we can certainly, we can see about doing that, certainly.
Okay, great. And then Mary Williams, if we have some additional information to add that folks can see with regards to smoking cessation, that would be great too. Because one of the things that we want to do with the Health Equity Committee is to share the information and get it out so that we can become a resource. So before Dalton speaks and updates us on his area, the rural area, Rosalie, I just want to find out if you have anything you want to talk about before I know you have to hop off for that other meeting. So, or invite everybody to the other meeting for that matter. I'm opening up to you at this moment.
Thanks, Daryl. Lindsay, thank you for presenting. It's always such great information, and certainly appreciate your work that you're doing in that area with the BIPOC group. And then I think it would also be helpful to our LGBTQ group as well as we're working through things. I just want to say I'm appreciative of all of our work groups who have been getting together and meeting. Daryl and I have been tag teaming it, and everybody's group is doing really great work. So I just appreciate everyone's commitment to this effort. And as always, for those of you who may not be on a work group, if you're interested, we are always happy. I know Mary has a call out for our folks, particularly in the eastern part of the state. If there's an interest in working on our BIPOC group, we would love to have some folks on the eastern part of the state. So please give that some consideration if you have been thinking about joining one of the work groups. And that is all I had.
Okay, great. And just to add to that, Katie sent me a note. She was not able to come today. So just to say that the LGBTQ plus group is continuing to work on the survey. And so it should be out soon. So when you see it, we would like for you to participate and submit the survey so that we can collect more data to use so that the LGBTQ plus group will know the direction that they need to go. So thank you for that. And thank you, Rosalie. All right, Dalton, for the rural group, thank you for being here today.
No problem. Happy New Year, everyone. Good to see you all. Hope you all had a restful break. And sorry if I sound a little nasally. I'm kind of fighting a cold like it seems like everybody else is. But we're gonna get through it. I don't have a ton to update on. The rural group has not met quite yet this year. I think we're looking at probably 2 weeks from now on Friday. I think we've really hit on kind of this digital equity focus, and then also talking about how the area health education centers are kind of working to build healthcare workforces. I think I'm going to try to get the group together and kind of discuss on, where our work this year can kind of help those and how that stuff can kind of fit into our work. But I think those are going to be kind of our main focuses this year when it comes to that. But I think next time I'll have a little bit more to update on. But yeah, it's good to be back.
Okay, great. Thank you, Dalton. And the digital work will be important as we talk about people don't have access, that it will really help us to learn how that can be better so that folks will have a little more access with regards to the digital.
Daryl,
Well, ladies,
Daryl,
yes,
this is Mary Bethel, and also
yes.
Dalton. There's probably going to be a work group in conjunction with the multi-sector plan on aging that's going to be looking at digital equity also. So I would say this group probably needs to coordinate with with that group to the extent that you can. I think it really helped to maximize the efforts of both groups if you guys work together on that.
Could you
I
let me
think they're,
know who's running that group?
I will,
And you could
yeah.
just email me.
I know it's somebody with the digital equity thing for the state, as well as I believe somebody from the Division of Aging, if I
Okay,
remember.
awesome. Thank you so much.
Thanks, Mary, for that reminder. Appreciate it. So that would be great. We'll make sure, Dalton, too, that you have access to that individual, those individuals who are working on that. All right, that's excellent. We really have made good time today. This is great. Mary, Bethel, do you have any additional comments that you'd like to make? We're at that point
Not,
on
not
the
really,
agenda.
Daryl. Thank you. For those who don't know, I'm board chair for the Coalition on Aging, and we're so pleased that we have this health equity focus within the coalition and this committee and the subgroups that are working on this. I mean, just by the comments today, you see the importance of health equity and why it's something we really need to focus on. So thank you, everybody, for giving me your time and energy to devote to this. And I look forward to some real significant undertakings in this next year and what this committee and the work groups can do. So thanks everybody for your engagement on this.
And thank you, Mary. And I'm hoping, as we move along, because this has been brought up before, that we can tap into the work of the all ages, all stages, which makes it better, that we're combined. And because the coalition can't really do a whole lot of activities. We don't have the capacity for that, but we certainly have great minds thinking about what we can do and how we can connect with other organizations. So as you think about it and go along with your work, with your agencies, connect with us to see if we can join efforts, because that's the way we're going to get things done. This is slow, this didn't happen overnight, all of the inequities that we are seeing. So certainly the solutions are not going to happen overnight, and it's going to take all of us working together to continue this. And I think we have great folks already working together, and we can use more. So please get in touch with us if you're interested in joining the work for either of the work groups, the BIPOC, the rural, the LGBTQ plus, as we move along. Because as Lindsey pointed out, it all really is together. Whether we identify the group separately or not, we are all in it together. And there's a lot of intersections. So we want to make sure that we're touching everyone in the work that we're doing. And again, we'll try to get this out on the website so that people can access the information as you go along. So let's see, Dalton, Heather just wrote that she hopes you feel better. And she said drugs and tea. So take that however you want, Dalton, with the drugs and the tea. And agreed about the combined and collective energies. So thank you all so very much. Our next full committee meeting will be Friday, March 14th at the same time. We haven't identified the speaker. We will let you know what will be happening at that meeting at a later date. But again, if you're interested, contact Mary Williams Stover, Dalton Bailey, or Katie Kutcher, or Lindsey Golden, if you're interested in working along any of those areas. So I think that's it, unless anyone else has a question or a comment. Okay, ladies and gentlemen, just stay safe this weekend. Stay warm. Don't go outside if unless you need to. I'm not sure about North Carolina, but I'm kind of scared if we have snow because we're not used to it. I lived in Wisconsin for about 30 years, so I'm used to snow, but we always have accidents when the snow first hits. So be careful out there, and especially if we have ice here in North Carolina. So we look forward to you all connected with us in the meantime. If not, we'll see you in March. So take care and enjoy the weekend. Thank you so very much. And again, Lindsey, excellent. Thank you.